Thank everyone for joining us. I'm Matt Valier. I'm the Executive Director of the Patients' Rights Action Fund. For the benefit of some people with disabilities, I'm an early 40s man of color, dark wavy hair, clean shaven, olive complexion, wearing a purple and blue checked button-down shirt and a French blue blazer in front of a beige background. As part of our quarterly webinar series, we have Dr. Mark Comrade with us to provide an in-depth presentation on how assisted suicide endangers people with mental health disabilities. Dr. Comrade is a practicing psychiatrist and medical ethicist on the teaching faculty of Johns Hopkins University of Maryland, Tulane, and LSU. For over 20 years, he chaired the ethics committee for Sheppard Pratt. He has written, lectured, and taught nationally and internationally about ethical issues in psychiatry, including assisted suicide, certainly here in the States, but in many countries across the globe. He served 6 years on the American Psychiatric Association Ethics Committee and the APA Assembly. In these two capacities, he helped craft the APA position statement opposing assisted suicide and medical euthanasia for non-terminally ill, particularly psychiatric patients. We also have with us a American Sign Language interpreter and captioning for those who would benefit. To turn on the captions, if you move your cursor around a bit, the toolbar comes up at the bottom of the screen. There's a little symbol that says CC. You can click it to start the captions, and if you would like, you push the up caret, which is in the upper right corner of that same button, in order to get caption settings. You can adjust the settings for the captions to your liking. A little housekeeping. We're going to take questions today via the Q&A function that's also available when you move your cursor around. Next to the CC button is a question mark button. It says Q&A below it. You click that button and you type in the questions that you have. Please type the question, your name, and if you're a journalist, your media outlet. For any further media inquiries, please contact Meg Tully at mtully@apcoworldwide.com. That's APCO worldwide.com. The session will be recorded and we'll share the link on our platforms afterward. Dr. Comrade will not be providing the slides for distribution, as you can reference them on the recording. So, Dr. Comrade, thank you again for joining us, and please take it away.
Thank you so much. All right, let me just technically get to, wait a minute, get to the right share screen here. There we go. Am I sharing properly now? Is that okay?
Yeah.
Okay, great. Well, thank you so much. I really appreciate the invitation and opportunity. Very much appreciate the work that the Patients' Rights Action Fund is doing. And in fact, I know that this is a central core theme for you all, as it has become for me. In many ways, my entire career as a psychiatrist and medical ethicist sort of prepared me for this particular topic that has really been a core focus of my work in ethics and as a psychiatrist, and frankly, a gradual transformation from an ethicist into an activist on this issue. I feel so strongly about it for reasons that I'm going to share with you. I'm just starting here with this picture of Jane Allen, which comes from an article that Matt Valier wrote in the Denver Post about his friend, Jane, who had anorexia nervosa and was offered in Colorado, and we'll be getting to that remarkable passage, a opportunity to have physician-assisted suicide, which she declined and was on the road to recovery when she had complications and ended up dying, but not from physician-assisted suicide. So I want to dedicate this talk to Jane Allen. So as Bob Dylan famously sung, the order is rapidly fading, for the times they are a changing. So many different ways that we're seeing things topsy-turvy, and the set of value systems and priorities that we've had in as a society is being literally rewritten before our eyes. Indeed, in the domain of principles and ethics, integrities, and morality, we're seeing flashing red flags every time we turn on the news, radical changes in normative values, the way things were, and an increasing concentration on consequentialist ethics in which the ends justify the means. And there's really no more remarkable place where these times are changing as this particular illustration of physician-administered deaths worldwide that has been growing since actually even before 2003, but especially since that date, growing, as you can see, exponentially. And here, accumulated from around the world, is data on the two procedures that dominate this particular set of laws as well as practices, assisted suicide and euthanasia. And just very quickly, assisted suicide is where a physician or other clinician prescribes a lethal cocktail to a patient on request, on demand, with under certain criteria articulated by law, but the patient takes those oral medications at the time and place of their own choosing, with or without witnesses, by the way, with or without any ability to determine whether coercion is involved. But assisted suicide is an oral method. Euthanasia, on the other hand, is the term that we're using to describe the intravenous administration of a lethal injection on request by a physician in order to terminate life. So the two of them together, which comes under various names, assisted dying, medical assisted death, but you combined, you can see that they're taking off around the world. And I will say that in most jurisdictions outside the United States, the predominant method is euthanasia. And as a matter of fact, where both of these are legal, both of these methods, patients far prefer to outsource this as a medical procedure to a physician in order to do the deed to terminate their life. And we'll talk about some of the implications of that for psychiatric patients and suicide prevention. But since we're talking suicide, let's just pay a few moments of attention to this word. As Lewis Carroll wrote in Through the Looking Glass, Humpty Dumpty says, "A word means what I want it to mean, nothing more, nothing less." Ownership over this word is a very powerful thing, and people on both sides of the discussion are trying to bend its meaning, particularly people who are advocates for these procedures, to bend its meaning away from the venerable and centuries-long established meaning of this word. And this is a word, as a psychiatrist, that is clearly in my domain and part of my daily bread and butter as a person whose career is dedicated to preventing people from taking their own life. So George Orwell said in 1984, a book that seems so increasingly prescient these days, if thought can corrupt language, then language can corrupt thought. And indeed, that's very much the case with how this word suicide is used or not used. The ordinary definition, the definition that we psychiatrists use in the course of our daily work and have long recognized, and that the Centers for Disease Control here in the US has defined suicide as simply the death caused by self-directed behavior with an intent to die. Very straightforward definition. However, at one point, anyway, the American Association of Suicidology decided that that word suicide would not apply to the procedures that we're talking about today. They claimed legal physician-assisted deaths should not be considered cases of suicide. Why? Because patients do not want to die, but merely to end their suffering. And therefore, if we basically terminate the life of the sufferer, we're terminating their suffering. So they tried to parse this as something that's not suicide, even though it very much, according to this definition from the CDC, very much is self-directed behavior with an intent to die. using the term medical assistance in dying, which is actually the increasingly popular term, especially in Canada, says my colleague, John Mayer, is an attempt to separate suicide from its value-laden meaning in thousands of years of moral reflection. Here are two different pictures of suicide as we see it today. One on the left is the Golden Gate Bridge, which invested $225 million to build that safety net that you see to basically try to both dissuade and also capture people who are attempting jumping from the Golden Gate Bridge, the single most popular place from which to jump for suicide in the world. On the other hand, on the right, we see the MAID House, medical assistance in dying, the Canadian term, which is in Canada, which is basically kind of like, for those of you who may remember, Soylent Green. It's a place where you can go and, if you qualify, have your euthanasia. Two very strikingly and starkly contrasting views of suicide in the Western Hemisphere today. So the problem with trying to articulate these two different ways of thinking about suicide is it creates these two tiers, the bad suicide and the good suicide, because I really want to maintain to you by these definitions, we are talking about suicide in either case. So on one hand, we have the suicide that we should prevent. And on the other hand, we have the suicide that we should provide on the basis of both these laws as well as um, our intentions to honor people's autonomy and so forth, the arguments that go into it. So we have these two suicides, the good suicide we should prevent and that which we should provide. The former we designate as a pathology, as something that we want to intervene with medically. But the latter we have as a potential medical treatment. So we now have doctors in two positions. One, which is trying to prevent the pathological behavior of suicide as we've long come to understand it. And on the other hand, to administer suicide, to provide suicide rather than to prevent it. Well, this is an extraordinary conundrum. And in fact, being able to distinguish these two different kinds of suicide is in the real world, in the clinical trenches, absolutely impossible. And much has gone into studying that. So for that reason, ultimately, the American Association of Suicide decided in 2017 to retire their statement, to actually take a step back and admit that you really can't distinguish one kind of suicide from another. So that position has been retired for further study. All right, let's now turn our attention specifically to these medically administered suicide scenarios for people with psychiatric disorders, which is actually taking place in certain living laboratories around the world. And I first want to acquaint you with what's going on out there in this particular domain. And to do that, we have to cross the Atlantic and start with the Benelux country, Belgium, Netherlands, and Luxembourg. So those countries, back in 2003, when we're talking about this, there's sort of two considerations. One is the suffering of people from various conditions, and the other is the notion of whether their conditions are terminal or not. Well, these countries decided that in terms of balancing the focus on suffering versus the focus on terminal illness in the context of whether or not such procedures would be allowed, they basically decided to elevate suffering over terminality and focus their laws entirely on dealing with suffering, not necessarily strictly terminal illness. So back in those years, 2001 to 3, they got out of the discussion of whether a condition is terminal or non-terminal with regard to eligibility for these procedures, and instead replaced it with the notion of the conditions that are both untreatable, as defined by a doctor, although also as defined by the treatments that patients are willing to accept, and whether the condition is unbearable by the patient. So no longer whether it's terminal or not, it's whether it's unbearable whether it's untreatable. And also, they got out of distinguishing the difference between physical and mental suffering, which, interestingly, and I would say somewhat ironically, is what we psychiatrists have sort of been trying to promote all along, that our patients' suffering is as real and as meaningful as people who have cancers, for example, and other serious somatic conditions. So they effaced the difference. Suffering is suffering is suffering. And they legalized euthanasia in addition to assisted suicide. But as I said, when you have both, the predominant activity is euthanasia. So with this formula, allowing euthanasia for people who have conditions that are untreatable, unbearable, and they're suffering, no matter what kind of suffering, that combination opened the door for people with psychiatric disorders to be eligible potentially for these procedures. So let's see what's happening. First, let's look at the Netherlands. So there, things have really taken off. And since 2003, there's been over a 500% increase in the number of people who have died each year by euthanasia. Last year, we were up to nearly 10,000 people. Last year alone died from euthanasia. And as a matter of fact, almost 6 out of every 10 human beings who die in the Netherlands die at the sharp end of a doctor's lethal injection. In some cities in the Netherlands, as many as 1 in 10 deaths are by euthanasia. Think about that. 1 in every 10 people you know who died in cities like Utrecht die because their life was deliberately terminated on request by a lethal injection from a physician. And by the way, this report in New England Journal says that actually a large percentage of euthanasias there don't get properly reported. So these are actually underestimates of what's going on over there. And one study in 2021 showed that there are even patients who are not competent in comas or have end-stage dementia who have been euthanized without request, 517 in that particular year. In other words, mercy killings by physicians. Now, with regard to people with psychiatric disorders, which, as I've explained to you, is they're eligible in that country, you can see the steady rise of this. And as a matter of fact, in the last 2023 to 24, there was a 60% increase in the number of psychiatric patients who've received euthanasia there. So 219 out of a total of about 10,000. So obviously it's a small proportion, but still that's really quite remarkable that 219 people had their lives terminated because they had psychiatric disorders that were considered untreatable and insufferable. And in 2024, 14%. So basically about 1 out of every 6 of those people, those 219, were young, were under age 30. And that's becoming an increasing phenomenon. This professor of ethics in Holland said, I'm observing euthanasia becoming some sort of acceptable option, especially for young people with psychiatric disorders, where the healthcare professional seems to give up on them more easily than before. We're going to return to that in a few minutes, but I want you to see here how this thing has evolved, how a society that has become, in which this has become normative, is becoming increasingly besotted with this as an option for ending the life of people with psychiatric disorders. 2012 to 18, there were only 29 requests from psychiatric patients for euthanasia. By 2022, in that year alone, 781 requests from psychiatric patients for euthanasia. And in that year, in this study, 50%, 1 out of every 2 psychiatrists in Holland, received requests for euthanasia from their patients. Imagine that. Imagine being a psychiatrist and, that half of the psychiatrists there have received at least one, if not more, requests of patients to ask for euthanasia to provide them suicide as a treatment plan for their disorder. In 2023, it went up to nearly 900 people, of which 15% were actually granted. And here's the thing, in this particular study of 72 cases in those years, over half were actually euthanized by a psychiatrist. Imagine being a psychiatrist and actually starting a lethal injection to end the life, to comply and abet and aid and provide suicide for your suicidal patient. And indeed, imagine being an exhausted psychiatrist who is treating somebody that you are really struggling with, and your own feelings of hopelessness, many that could actually have been absorbed from your patient, which actually happens, and your own sense of futility, then actually both either approving or administering. As a matter of fact, data suggests that of these cases, between 1/4 and 1/3 of them were euthanized by their own treating psychiatrist. Their own treating psychiatrist. Here's a review of 66 cases. You can see the different diagnoses of these patients who were euthanized. What really especially challenges belief is that, almost 1 out of 10 of these people actually had psychotic disorders and were considered, nevertheless competent, having capacity to consent to having their suicide provided. But most importantly, we're seeing increasingly that half of patients also qualify for a diagnosis of personality disorder. I'm not going to get into what we mean by personality disorder, but I do want to say that the state-of-the-art treatment for personality disorders is psychotherapy. And of these 66 patients, the 28% of these people with personality disorders never had any psychotherapy whatsoever, even though that is the accepted standard of care for the treatment of people with personality disorders. Now, I want you to be clear that it's not without any pushback. There's an increasing group of psychiatrists that are really pushing hard against their very own psychiatric association that has actually been supportive and complicit in both endorsing and indeed even promoting. Can you imagine the Psychiatric Association in the Netherlands is even promoting this option for some psychiatric patients? And this pushback, they wrote a letter to the organization. These psychiatrists said, the grave concerns and the well-substantiated medical and moral objections of the large group of psychiatrists who are critical of the current euthanasia practice are being painfully ignored. Some psychiatrists are already experiencing moral trauma as the result of the questionable way in which we as a profession are handling euthanasia requests from vulnerable patients who within our current healthcare system have fewer and fewer chances of timely and appropriate mental health care. I also want to point this out, okay? So about 1% or less of all euthanasians in the Netherlands are psychiatric. Now, in the Netherlands, you are allowed to sign up that after your euthanasia, your organs can be donated. All right. So if you look at all organ donations after euthanasia, even though only 1% of the euthanasias are psychiatric, 29% of all organ donors after euthanasia had psychiatric conditions. They were psychiatric patients. In fact, here are the diagnoses of the 24 donations that went into that. So who have really the most desirable organs for donation? Well, frankly, people with psychiatric disorders who are much less likely to have diseased organs. And therefore, it represents a kind of virtue opportunity, a sort of coercion to say, well, my life doesn't feel like it's worth anything. I feel like my life is a failure. I'm ready to have my suicide, my euthanasia. But wow, I can give life to somebody else. So in many ways, it's preferentially drawing psychiatric patients into this organ donation pipeline. Here's one particular patient who said, I thought the knowledge of having full autonomy by way of MAID was comforting, but when the possibility of organ donation was added to it, the sense of elation is the only appropriate word for me. Perhaps it's no wonder that such a large percentage of people with psychiatric who are having euthanasia for psychiatric conditions are actually under age 30 in the Netherlands. Now, let's look at Belgium, which has also joined this club. And remember the 500+%? Well, in the same years, Belgium has had over a 1,400% increase in euthanasia since they first began. And between 3 and 4 of every adult in Belgium dies at the sharp end of a doctor's needle. Again, they have also their own psychiatric patients. By the way, in both of these countries, the majority of patients who are being euthanized for psychiatric conditions are women. We can maybe talk about why that is. They too have seen a significant increase. There was this downturn back in 2020 because in 2019 they changed the law there, saying for psychiatric patients and only psychiatric patients, not anybody else, they cannot refuse any evidence-based treatments. They must comply with all evidence-based treatments until they're declared untreatable or treatment failures. So that knocked it back, but then it's been recovering ever since. Again, here's a group of 57 patients, and you can see still the most common diagnosis are personality disorders. And by the way, for those of you who understand that what personality disorders are all about, the vast majority of those people have borderline personality disorders, which if you understand that condition, that's probably no surprise, but I'm not going to divert into that. What happens when you've been living with this in a society after 20 years of doing this? Well, look what happens. Now, after 20 years, a recent survey said 75% of all psychiatrists endorse this, say euthanasia should be available for patients with sole psychiatric illnesses. And 8% of psychiatrists are actually now say they'd be willing to terminate the life of their own patient, to start that IV and to push the lethal injection for their own patients. This is what happens when you live in these kinds of societies with this sort of a euthanasia regime after a while. Robert Lifton, who studied Nazi doctors, coined the term, malignant normality, the imposition on society of a set of expectations that are highly destructive, but are rendered ordinary and legal. Now, there is plenty of pushback in Belgium. This is an interesting development. The Reakiro House, which Reakiro means recovery in Esperanto, they specialize in attracting people with complex psychiatric disorders, people who've also had a lot of past suicide attempts who are interested in euthanasia. But their mission is not to administer euthanasia, but to get people talking and to possibly help them find a path to a better future. They're not explicitly against euthanasia, but at least the hope is through conversation and support, maybe some of these people's euthanasia, suicidal intentions can be diverted. Now, let's turn to Canada, which, in terms of what you've seen so far, the data from Canada is remarkable. There is kind of a euthanasia frenzy going on. In 2016, they passed a law legalizing euthanasia, but they didn't use the word terminal illness. They said for those whose death is reasonably foreseeable. They invented that term. Nobody knows what it means. It was not statutorily defined, but it was felt to at least imply people who are close to the end of life. So they opened the euthanasia regime to people who are in that category. They can refuse evidence-based treatment, making themselves terminal. If you have end-stage kidney disease and you don't want a kidney transplant or dialysis, you're making yourself terminal. Your death is in the reasonably foreseeable future. Now, mental illness was not explicitly excluded, but in general, it was felt that you can't reasonably foresee death in a psychiatric patient, so patients were at least de facto, if not de jure, excluded if they had psychiatric conditions. However, then, after a couple of years of running this, they got again into the calculus of what's more important, that a person's at the end of their life or a person is suffering, and they decided to follow the Benelux model. And in 2021, they passed a new law that divided things into two different categories. One, track one, patients whose death is reasonably foreseeable, again, not defined. Previously, those people had to wait 90 days between evaluation and their euthanasia. However, with the new bill, if you are in that category, you can get euthanasia the same day you're evaluated. But then there are track two, which basically resembles the Belgium and Netherlands model. Anybody with a chronic illness and disability that is irremediable and intolerable. Remember, those are the criteria in the Benelux countries. So if your condition is irremediable, again, if utilizing, you're allowed to refuse treatments. So if you refuse a treatment, uh, and that's the treatment that can remediate you, you are now irremediable. And if you say it's intolerable, it's intolerable. So those people are now eligible, but they have to wait 90 days. Okay. Uh, and again, no statutory requirement for any evidence-based treatments. At the last minute, just before the bill was passed, they introduced a stipulation that said, okay, nobody with mental illness is excluded, psychiatric disorders are excluded, but it's only excluded for 2 years. And in 2 years, we're going to open the door to psychiatric patients like in Europe. Um, Meanwhile, we'll develop the protocols. Well, the fact of the matter is this issue about irremediable. A number of experts, including all the academic psychiatry departments, weighed in and they basically said, really? Well, the fact of the matter is that psychiatric illnesses, there is no evidence, says this particular report, for example, no evidence anywhere in the world's literature that supports being able to identify irremediability in any individual case of mental illness. So people argued considerably that if irremediable is the criteria for this new track two in Canada, it can't apply to psychiatric patients. Well, that pushback resulted in this sunset being delayed from 2022 to 2024. And just as it was coming up to open the gates for psychiatric patients in Canada in 2024, the hue and cry continued, pushback continued, and now the can has been kicked down the road again. And in March of 2027 now, it's expected to open to psychiatric patients. All right, so what's been going on since these laws have developed? Well, do you remember the percent increases in Belgium and the Netherlands? Well, over in those countries, that was over the course of 21 years. Here in Canada, since it's been 2016, in the course of only 8 years, there's been an over 1,500% increase. There have now been a total of 90,000 plus Canadians who have died by euthanasia. 5 out of every 100 Canadians in Quebec, 7 out of every 100 Canadians have been euthanized. By the way, it's not a very popular procedure for doctors to do. Though there were over 13,000 doctors in Canada in 2022, only 336 doctors were willing to provide this service. But as a result, though, because it's become so increasingly popular that medical assistance in dying, euthanasia predominantly in Canada, is now the sixth leading cause of death in Canada. The sixth leading cause of death in Canada is basically being killed by a doctor. So I've had a little technical problem here. Let me get rid of that. Let's see. Let's redo this again. There we go. Sixth leading cause of death. So the fact of the matter is, although mental illness is not explicitly yet allowed in Canada as a criteria for euthanasia, this publication by the government of Canada said, although persons suffering solely from mental illness wouldn't be eligible, persons suffering from both a grievous and irremediable physical medical condition and a mental illness would not be excluded. So, for example, someone suffering from clinical depression who also has a spinal cord injury, they're eligible. So right now, the exclusion applies to people who have only mental illnesses, and there are plenty of people with physical illnesses who have psychiatric conditions. So, for example, this study showed that in these track 2 patients who were non-terminally ill, depression, anxiety, PTSD, personality disorders were common. Nearly 40% of people with those conditions also had one of the with physical conditions also had one of these psychiatric conditions. And unfortunately, prior to euthanasia, only about 5% of people ever were sent for a psychiatric consultation to give a psychiatrist a chance to see if they could dissuade those patients, treat their psychiatric conditions. I'm depressed, doctor. Oh, well, have you considered suicide? That's the scenario. Now, as in all the other countries, there is pushback on this. And in fact, a bill was introduced in the Canadian Parliament this past June that would repeal the intended expansion of euthanasia to those with psychiatric disorders. And that bill is still currently being debated. Just want to touch on Switzerland. Switzerland is notorious for allowing suicide tourism. So of this nearly 4,000 assisted suicides, they don't have euthanasia, they have just assisted suicide in those years. 482 were people who had primary psychiatric disorders, which is 13% of all the assisted suicides in Switzerland. And 30%, one out of every three of those psych patients, came from other countries to get their assisted suicide in Switzerland. A brief touch in the United States. Here in the United States, as you all who are paying attention to the Patients' Rights Actions Fund know, we have 12 jurisdictions that have legalized assisted suicide, not euthanasia. Nobody has. Illinois is right on the verge. The governor may be any day signing into law the bill permitting that in Illinois. Psychiatric illness is not explicitly excluded in any of these jurisdictions. However, that does not mean psychiatric patients, as we will see shortly, have not had these procedures because, again, no law says explicitly no one with a psychiatric illness can have it. Now, here, the original law was in Oregon, and other states have modeled themselves on this. In fact, nationally and internationally, there's a lot of talk of the Oregon model because Oregon goes all the way back to 1998. So the Oregon law says if, in the opinion of the attending physician, a patient may be suffering from a psychological disorder or have impaired judgment, then the physician shall refer the patient for counseling. So in the first couple of years, people were mindful and concerned about this, but as this thing got underway and started to accelerate, somehow the referrals for psychiatric evaluations of patients started to disappear. So that lately, in these last few years that have been studied, fewer than 1% of patients are ever referred for psychiatric evaluation. And the fact of the matter is, there's a tremendous overlap between terminal illnesses, which is all we're limited to here in the US, and mental illnesses. About 50% of patients with advanced cancer, for example, actually also meet the criteria for a psychiatric disorder. Here in this one Oregon study, they took 58 patients who had already been granted their assisted suicide prescription and studied them. And it turned out that 31% of them actually had clinical depression, the diagnosis of which was missed by the evaluating physician who said, no psychiatric problems, let's give them the assisted suicide pills, the box of barbiturates, the box of barbs. And it turns out 31, almost 1 out of 3, they missed the depression. None of them were identified. 7 of the patients, when interviewed, said it didn't matter to them that they were depressed. They still wanted to die. And they offered all of these people free psychiatric treatment, of these 15 patients. Only 1 accepted the referral. So now, it turns out that, as we heard at the very beginning, when we talked about Matt's friend, Jane Allen, that in Colorado, there have been 3 cases of patients who were presumed to have something that is not a generally acceptable construct in clinical psychiatry of so-called terminal anorexia. They were felt to be hopeless and untreatable, and therefore they were deemed terminally ill. Again, not an acceptable concept in psychiatric practice today. But this particular clinician thought, Jennifer Gardiani, thought that she identified 3 cases that, in her opinion, were terminally ill and provided all 3 of them with assisted suicide prescriptions. 2 of them used it and died from her prescriptions as intended, and 1 died before they could use it. So there have been at least 3 published documented cases of psychiatric disorder, anorexia nervosa, that have died in the United States by assisted suicide. In fact, it turns out we've discovered 30 additional cases in which the documentation doesn't say anorexia, but says severe protein calorie malnutrition. We're not able to get the medical records of those because of HIPAA laws, but we strongly believe that this may be a cover for what is actually psychiatric disorder, anorexia. So these 3 cases may not be the only ones. And we know that it was offered here to Jane Allen, Matt's friend, but she never used it, though she basically, her life ended due to her illness anyway. In this wonderful paper, the authors documented 66 clearly documented cases worldwide of anorexia that have been either euthanized or given assisted suicide. Now, let me reflect on the ethics. The way I see it, unethical ethics are better than no ethics at all. That seems to capture something about our current time, our current zeitgeist. I want to remind you that although many of these jurisdictions have these as legal procedures, that legality is not the same as morality. The Holocaust was legal, hiding Jews was criminalized, slavery was legal, freeing slaves were criminalized, segregation was legal, protesting racism was criminalized. So just because something is legal doesn't mean that it is right. Wrong does not cease to be wrong because the majority share in it, said Tolstoy. So I want to just touch on 3 ethical arguments, particularly the last one, that typically are cited in favor of assisted suicide and euthanasia: autonomy, justice, and futility. Now, with regard to autonomy, the leading textbook of medical ethics is this textbook, Principles of Biomedical Ethics by Beecham and Childress, that is used in almost every healthcare educational setting around the world. And there they define autonomy as self-rule that is free from both controlling interference by others and from inner limitations. And I want to submit to you that in particular in psychiatry, the illnesses and the conditions that people suffer from very much constitute inner limitations. And this one patient argues serious mental illness undermines a patient's personal autonomy, the capacities of a person that enables them to live a meaningful life of their own making. And indeed, some illnesses absolutely corrupt decision making. Anorexia, in particular, it's the illness itself that resists the treatment. It's the illness speaking when a person says, I don't want you to feed me. With regard to justice and fairness, we often talk in psychiatry about parity, that our patients should be treated the same as everyone else. The problem is, wherever you draw the line as to who's going to be eligible for these procedures, those just on the other side of the line say, well, why not us? If terminal illness, 6 months, well, why not 7 months or 8 months? Physical suffering, well, why not psychiatric suffering? 18 years old, well, why not 17 or 16 or 15 years old? Why not, being able to make advanced directives? Any line that you draw that excludes any group is highly susceptible to arguments on the basis of the principles of fairness and justice, to be able to expand the eligibility to include that. And I think this is one of the things where any jurisdictions that sets up criteria like somatic illnesses within 6 months, with 6 months left to live, that's the low-hanging fruit that you start with. And inevitably, in every living laboratory around the world in which these procedures have been rolled out and legalized, we see the gradual moving of the goalpost, the gradual stretching, and that's how psychiatric patients ultimately come to be included. Now, for so many of these places, the ultimate gate to getting in the door to these procedures is that your condition is considered futile. And I just want to argue about the whole idea of whether psychiatric conditions are ever futile. And because of these three different considerations. One, which is the fact that unpredictable diagnoses and prognoses are very much the rule here in psychiatry. The fact of the matter is that diagnostic reliability is only about 66 to 76%. In other words, the fact that the possibility of two different psychiatrists agreeing on the diagnosis only happens 66 to 76% of the time. And we often see psychiatric diagnoses changing over the course of a patient's treatment course, because there's, for a variety of reasons which we can discuss. But the point is that diagnosis is a necessary prelude to prognosis. And if the diagnosis is unreliable and wobbly, so is the prognosis. So indeed, that's why the science of prognosis, when it comes to predicting the course of psychiatric illness, is very, very underdeveloped. We cannot predict irremediability when it comes to mental illness. Big difference between being able to predict the declining course of well-known medical ailments with understood biology, even if it's not 100%, and it turns out it's definitely not, certainty, versus making unpredictable assessments about the course of mental illness. Then another issue with psychiatric patients is tremendous inaccessibility of treatment due to inadequate treaters, inadequate manpower, not enough time to deal with patients, not enough resources, stigma, biases such as ableism. The World Health Organization says the number one cause of inadequate recovery mental health disorders is inadequate financing, facilities, treaters, and experts. Financing are a big issue. There's a very high rate of being uninsured among the mentally ill, inadequate parity of insurance for those people who do have insurance. And psychiatric patients are very likely to be socially marginalized in the economic underclass. And now, with the latest changes in this nation, with the reduction in Medicaid, they're especially in peril. Medicaid is the single largest payer of mental health and substance use services in the United States. And the burden of behavioral health conditions is much higher among those who are Medicaid enrollees. So the retraction of Medicaid that we're seeing with the latest political changes make our population of people with these disorders especially vulnerable. And people with mental health disorders are much more likely to be in the lowest quintile of socioeconomics. And as Roosevelt said, necessitous men are not free men. And that very much impinges on the whole issue of the autonomy and freedom that people who are suffering psychiatrically, whether they have a somatic illness or not, are susceptible to. And then I want to say that here's the problem with these two different kind of suicides, those that we should prevent and those that we should provide. By providing suicide, we are medicalizing it. We are outsourcing the responsibility for suicide to physicians. And I really submit to you that this is very problematic because it is basically removing something that's very important in suicide prevention. And that is that suicide is a taboo. Now, mind you, taboo is not the same as stigma, right? Taboo means it's not good, it's uncool, it's something you shouldn't do. And I cannot emphasize how important that is to suicide prevention. Well, by outsourcing, morally outsourcing, putting this hand to the physician, dressing this up in the white coat of medical procedures, legitimizes it, validates it, and basically gives a sense that there are certain suicides that should not be taboo. And I cannot emphasize enough the potential way in which that can undermine suicide prevention. In fact, we've already seen this in these two papers. One, legalizing euthanasia was followed by an increased rate of natural suicide, if you will, in women in those three places. And that in Australia, after legalizing assisted suicide, there was a 42% increase in the suicide rate in the elderly, right? So basically, removing the taboo, it's this incredible natural experiment has shown that people are more likely to actually avail themselves of self-administered suicide after doctor-administered suicide has become legalized. Look at this. In the United States, okay, 1998, Oregon legalized assisted suicide. In the subsequent 20 years, there was a 28% increase in suicides in general in the United States, but almost 50% increase in ordinary suicides in Oregon. So Oregon has had almost double the rate of increase in their suicide after they legalized physician-assisted suicide. So I submit to you that as a psychiatrist, these procedures invert the fundamental ethos of what I and my profession is dedicated to doing, who we are and what we do. We prevent suicides. We do not provide suicides. It is a core fundamental mission that defines our profession. What do? We ameliorate symptoms. We help build coping mechanisms to help people who are demoralized and discouraged. We help to mobilize their support systems. We understand the context of suffering. We help people find a path to a better future. And indeed, if we can't ameliorate all suffering, we even have the skill set to make meaning of unresolved suffering. We have a skill set, and all physicians should, and we in particular in the mental health professions have the skills to deeply listen and accompany people in their journey of suffering, offering presence and hope. And I say that this is independent of any diagnosis. You don't have to have clinical depression or clinical anxiety, a DSM diagnosis, for us to be able to deploy this set of skills for people. And yet, no jurisdiction anywhere asks people to encounter a mental health professional in order to have it run at treatment. At most, they have to be in Hawaii. It's the only jurisdiction, by the way, in the United States where you have to be screened by a mental health professional just to make sure that you have capacity. And by the way, those mental health professionals don't have to be psychiatrists or psychologists. They can be educational counselors, family counselors. The law does not specify the level of expertise for that screening. Just as the Pope should not perform abortions and the Dalai Lama should not take up arms, psychiatrists should not counsel or abet suicide, for in doing so, we've misunderstood and betrayed our vocation and profession. Validation of suicide or assisted suicide, I want to say by any physician, but especially psychiatrist, is therapeutic and professional hypocrisy. As Wittgenstein said, if suicide is allowed, then everything is allowed. And the great medical ethicist of our time, Leon Kass, said the venerable Hippocratic Oath clearly rules out physician-assisted suicide. Without this taboo, medicine ceases to be trustworthy and ethical profession. We need to care for the dying, not make them dead. When psychiatrists, as in Holland, undertake to kill their patients with public support, intuition and revulsion have fallen asleep. Only argument, with all its limitations, can hope to reawaken them. And I hope my argument has awakened that point in you. And finally, with regard to the Patient Rights Action Fund, our host today, I want to remind you in terms, if you want to be part of the solution to this moral diversion, this malignant normality that's emerging, Bill McKibben, in reference to climate change, poignantly said, the most important thing an individual can do is be a little less of an individual and join together with others in movements large enough to make a change. Patients' Rights Action Fund is a vanguard of such a movement. Thank you very much. I'm going to stop sharing.
Well, thank you so much, Dr. Conrad. That was a tour de force here. So very much appreciate that. I'm gonna turn to the Q&A just to remind everybody, you may use the Q&A in the last few minutes we have remaining. If you'd like to put a question before Dr. Conrad, if we don't get to it in the next couple of minutes, we would ask him to answer. We could send that to you via email. So your colleague, Dr. Ron Pease, is asking if we have any reports on how often assisted suicide is carried out in the context of the physician's feelings of futility, exhaustion, or even anger toward the patient. He said, it seems to me that this would be very hard to evaluate, yet an important factor in many instances of assisted suicide.
Yes. Well, what we certainly know, we have data showing that in at least 15 to 20% of cases, that the opinion of the first and the second psychiatrist, when reviewed by a third psychiatrist, they feel that the decision, this is in retrospect, the decision to have granted euthanasia, and this is in Netherlands, was made on the basis of the primary treating psychiatrist's difficulty with emotionally dealing with their patient. So in terms of an independent audit, about 15% to 20% of the cases have shown that indeed that has been a factor. Look, in all medical relationships, and particularly in mental health, the intensity of the doctor-patient relationship leads to the transfer of emotions back and forth from the side of the patient to the side of the treater, including the transmission of hopelessness and helplessness. Matter of fact, we actually have a technical term that is transference and countertransference, and also projective identification, the way in which patients instill consciously and unconsciously emotions into the treater in order to be able to see how the treater copes with those emotions and then identify with how the treater is dealing with those emotions. So indeed, it is a very, very much a interpersonal transmission of hopelessness. Also, we also see there's a lot of data showing how traumatizing participating in these kinds of procedures have been to doctors. And as a result, We know, for example, in Oregon, uh, most physicians who prescribe have only done this once or twice, but there's a zealous few. There's one particular physician who has prescribed 30% of all lethal prescriptions in Oregon has been prescribed by one guy.
Hmm.
So people can become, quite zealous about this, but the average physician doesn't even want to do it in the first phase or tries it once or twice and becomes too traumatized and backs away.
So, Dr. Comrade, we're at the top of the hour, but to close out, um, you just said something that was very poignant, and that the patient will sometimes ask something of the psychiatrist in order to gauge the reaction. Um, have you understood through your research, conversations with others, um, that in the context of requests for assisted suicide and euthanasia, that many patients are in fact um, encouraged implicitly by the very fact that the doctor's open to the prospect?
Well, I think that we do know that uh, doctors who are open to it, I mean, obviously, more of their patients end up getting these procedures. But we also know that when in psychiatric patients, I hear this a lot from my colleagues in Belgium, who have explained to me that many patients there utilize the opportunity to request euthanasia as a way of arousing the treatment system with a certain degree of alarm to try to provide them more services. So there have been, to try to say, well, okay, wait a minute. Before we talk about euthanasia, let's really be sure that you have gotten everything that you need. So many people have been able to, ironically, uh, mobilize the system by walking to the edge of the cliff, peering over, asking to be pushed over the cliff, and having the clinicians say, "Well, wait a minute. Let's see if there are any other stones we can turn over to be able to help you." So done kind of a jujitsu maneuver
Mhm.
to utilize this system as a way of getting more treatment services. It's kind of perverse if you think about it.
Well, Dr. Conrad, we're obviously past time. It's been riveting. I think we could probably go on for another hour just with various questions, even my own questions. But to respect people's time, thank you so much again. For those of you who asked questions that have not yet been answered, we're going to forward those to Dr. Conrad for any written commentary he might have and try to revert that back to you. And then if you want to learn more about this issue, Dr. Conrad has written quite a bit on it and has provided other presentations that are also recorded. If you,
Matt, before you go, I do see one question, which is about euthanizing our pets. How come we can't euthanize people? I want to point out if you just Google my name with pet euthanasia, you'll see that I wrote a paper on that topic, distinguishing what actually is the difference between euthanizing our pets, because that question comes up a lot, and I
yeah,
decided I really needed to write about that to be, clear about the divergence and disconnect between those two different euthanasias. So anybody
perfect.
who's interested in that question, just Google Mark Comrade and pet euthanasia, and you'll find the paper.
In any variety of aspects of this issue, Dr. Conrad has had written and spoken on them. And obviously, we have a lot of resources on the Patients' Rights Action Fund website. And to learn more about how we hope to end the practice, at least here in the United States, from the perspective of assisted suicide laws and overturning them through strategic litigation, you can look at endassistedsuicide.org. Thanks again, everyone, for coming. And Dr. Conrad, thank you so much for,
Thank you, and I hope we've done honor to the memory of your friend Jane Allen.
thank you. Yes. Take care, everyone.
Bye bye.